So thank you, Maya, for that nice introduction. And let's talk about TAP blocks. So our objectives today, we are going to talk about the indications and contraindications of not only TAP blocks, but also the ilioinguinal and iliohypogastric block. We're also going to describe the block techniques. So TAP blocks, they're used as part as a multimodal pain relief for lower abdominal surgeries, for inguinal surgeries, and pediatric surgeries. Traditionally, they've been used as a blind technique where you rely on fascial clicks and pops. However, there are disadvantages just because you sometimes when you go and give those blocks or try and feel those fascial clicks, you really don't feel them or you don't know. And so there is a 10 to 25% failure rate. And there's also the increased possibility that you might go too deep and you might hit the wrong vessel. So you could major vessel injury, peritoneal injury, and also bowel puncture. So what are the advantages of ultrasound? So definitely it's been increased with regularity. It does allow for real-time guidance and direct visualization. It allows you to have direct deposition of local anesthetic real close to the nerves. It increases the block success rate. You can use less local anesthetic, and it does reduce complications. And the other thing we talked about yesterday is that because of morbid obesity, it's much harder to do these blocks and harder to see it with ultrasound. Okay, so let's talk about applied anatomy. So the iliohypogastric and ilioinguinal nerve, it arises from the first lumbar spinal nerve root. It emerges from the lateral border of the psoas major, passes obliquely across the quadratus laborum. It pierces the transversus abdominis muscle, and it continues in that fascial plane in between the transversus abdominis and the internal oblique muscle. And if you look, and I'll try and not be careful how I hit this. So right here is the external oblique. There's the internal oblique in the transversus abdominis. So 3, 2, 1. It's the external, internal, transverse abdominis. And where those nerves lie is in between the transverse abdominis and the internal oblique. So it traverses there, and it continues medially in it piercing the internal and then the external oblique. The ilioinguinal nerve goes in towards the superficial inguinal ring. And the good thing about these nerves is that it's purely sensory. So there's no component whatsoever. When you block these nerves, they're able to ambulate. So that's a good thing post-operatively. So this is just a diagram just showing the ilioinguinal and iliohypogastric nerves as they descend. Okay, so what about for postoperative cesarean section pain? Well, following a fan and steel incision, it has both a somatic and also a visceral component. The somatic pain is conducted via the ilioinguinal iliohypogastric block, it will cover only the L1 and L2 dermatomes. Where the TAP block, you'll have a bigger area of coverage, and that'll cover between the T7 and L2 dermatomes. So when you do a TAP block, you pretty much go in this area right here, and where the ilioinguinal block, iliohypogastric, is down here in this area. So as far as doing the ilioinguinal, iliohypogastric, their techniques are pretty much the same. It's just the areas are different. So the operator wants to stand on the same side of the patient that you're doing the block. You want to, it's indicated for intraoperative and postoperative pain relief for cesarean sections. In the needle size, you can use anywhere from like an 18 gauge 2E, 17 gauge 2E, to a 22 gauge block needle. What we've been using lately is those EchoStim catheters or block needles, which are really nice and they show up nice when you're using ultrasound. And then the transducer position, where you want to put it is in a line that connects the anterior superior iliac spine with the umbilicus. That's where you want to put your probe, and you go in a line towards it. I'll show you a nice slide that says that. And then as far as the anatomical landmarks, you want to look at the anterior superior iliac spine, the external oblique, the internal, the transversus, and also the peritoneum and bowels. So what you do is you palpate the anterior superior iliac spine in line with the umbilicus. You want to use an aseptic technique, and when you use the sterile conductance gel, I like to put it inside on top of the probe, over the sterile cover, and also I like to use the external gel too because it makes it more conductance and it allows for better visualization. So here's just shows it for the inguinal iliohypogastric. So here's the anterior superior iliac spine. Here's the umbilicus, and you put your probe in this area, and then you just move it in line, so wherever you can get your best visualization. And then you have your needle in line, and then as it pops through, it'll come into visualization. So I'll show you more slides that show that. So as far as the technique, so you stand on the side, the probes move to capture it. You look for the external oblique, the internal, the transversus, and also the bowel loops. And really, ideally, what you want to feel, and that's good confirmation, is you go and push your needle through. You will feel 2 pops or clicks, so that's sort of good realization. And you can inject medication. So what I like to do is give on each side 10 cc's of 0.5% ropivacaine or bupivacaine, and it will create a hypoechogenic bulging pocket, and I'll show you as we go on. So here's the muscle layers, and it's real pretty much easier. So here's the subcutaneous layer here. Here's the external oblique, the internal oblique, the transversus abdominis, and then you'll see the bowel loops. So first thing I look for is I don't want to hit the bowel loop, so I definitely decide that, and you want to stay well away. When you're doing a block, you want to get in this area right here. And in fact, this slide here shows the ilioinguinal hypogastric. So as you come down, you want to go right in this layer, in between the transversus abdominis and internal oblique. Okay, and this just shows it more. In those echo stimulation needles, you can see it right here. So good visualization, and that's where you want to deposit the local. So that just shows it some more. And this, here's the local anesthetic pocket, so it'll appear dark as you inject. And here's a video. It shows it's only about a minute or so. So you can see the needle going in. I feel like this is a show and tell talk that I'm giving, you know. So you can see it in real time. And a hypoechogenic is the local anesthetic. And there's the local. Okay, that's pretty much it. That's what it looks like. Looks the same for the ilioinguinal iliohypogastric, also for the tap block, the same layers. Okay, so let's talk about the tap block. Really much the same thing. Stay on the same side, same patient position, same needle size, transducer position. Where you want to go is you want to identify the external iliac crest, the inferior rib, and in a line in between it, mid-axillary line. I'll show you a nice slide. And identifiable anatomy is the same layers. So as far as the technique, you want to put the transducer probe transversely on the lateral abdominal wall, right in behind the mid-axillary line between the iliac crest and the inferior rib margins. You identify the 3 same layers and also the bowels, and you want the needles passed anteriorly and down, and it comes perpendicular into where the probe angle is. I'll show you. Nice slide. And it's positioned into the fascial plane between the anterior oblique and the transversus abdominis. So again, you want to feel 2 fascial clicks and pops. You want to inject about 20 cc's total, so 10 on each side, and it does provide a larger area of block than the ilioinguinal iliohypogastric. And here's your margins right here. So here's your iliac crest, here's your rib margin, and you go ahead and put your probe there, and then this comes right in line, and you'll see the same layers. Now, this is a male patient, and you can see better anatomy, but as patients are pregnant, it's much harder to see the desired anatomy. So those are your landmarks. And the old technique is they used to describe the triangle of Petit, and before they used ultrasound, what they did is describe this triangle. And pretty much it's the same areas that you use when you use the tap block. And if you look here, so here's the triangle Petit is right here, latissimus dorsi, and one of the external iliac crest in the rib cage right here, and here's the external oblique. And ideally, if you weren't using an ultrasound technique, that is where the needle would go. And this is how it's used in, when you're doing a tap lock. And here's, once again, so you want to identify bowel. Stay away from that. You want to cause any problems. So I always go there first and foremost, and then lift up and go in the area. And you can see the needle right in between the internal oblique and the transversus abdominis, and you can inject the local anesthetic. And this is showing some local anesthetic. This was a thinner patient, but see, here's bowel here, so definitely stay away. Stay up in this area. Okay, here's the video. So just like Dr. Charest said, you can just come here and see the video for sure. And this is sort of cumbersome. You can see that it takes a long time. So first you got to put betadine down. You got to get everything ready. There's a lot of people standing around, sort of like government work, you know, a lot of people standing off to the side. And you'll see that later. You almost need like a block room, or, you know, to do that, or have the time to be able and do it. And it's showing some things where they're putting the gel into the sterile sleeve. So they're getting ready to put the probe in there. And then I personally like to get the sterile conductance gel and put that on the outside too. It makes it a lot easier. So there's the gel. It's going in. And the ultrasound visualizations are pretty good. You can really see it. So there's the government workers in the background. You can see them. So another guy is holding the syringe, and so if you're really busy, it's, you know, you really have to have the time, and you also need the help. Okay, so they're getting ready to. Okay, and that's on the side. And you can see the 3 layers that you want to look. Stay away from down here, and pretty much in this area is where you want to go. And you can see the needle as it goes through. And you can see here's the needle. There. And so this is a bilateral. So not only you do one side, then you have to go and do the other side too. And you see the needle going in, and then we'll move on after he ejects the local. It's about a 4.5-minute video, so we'll cut it. Okay, look at the guy sitting in the background. I want that job. Okay, and I think, are they injecting yet? You definitely want to aspirate first, you know, before you inject. And I think he's injecting. Okay, well, let's move on. So just inject, and then you're done, and then you have to go to the other side. So what are the complications? There's definitely complications, and it's rare. By using ultrasound, you have less complications. It is more common with the traditional blind technique. Complications can be bowel perforation, femoral nerve blocks. You can get intravascular injections, intraperitoneal blocks, lower limb paresthesias, and also pelvic hematomas. Now, how did this come to be? Why did they start doing tap blocks? Well, Bell initially found that by using bilateral ilioinguinal iliohypogastric blocks, it significantly reduced the amount of IV morphine consumption used by patients in up to 24 hours. Gufez et al. Found it reduced supplemental opioid use. McDonald also found that the bilateral tap blocks reduced the 4 to 8 hour morphine consumption. But the problem with this, so this it started this craze about these blocks, but intrathecal morphine wasn't used in all these studies. So it does decrease the pain scores, it does decrease narcotic use, but intrathecal morphine wasn't used. So what about doing the tap block with these intrathecal blocks? So Canazzi, he did a study here, and they looked at intrathecal morphine compared to tap blocks. So they were isolated, 28 intrathecal and 29 tap blocks. They standardized the postoperative analgesia. They used 40 cc's total, bilateral blocks, and they measured up to 24 hours. And then they found that the median time to the first analgesic was longer in the intrathecal morphine group than the tap. So there was more benefit if you used intrathecal morphine or subarachnoid morphine. That's what SAM stands for. So, and they concluded that intrathecal morphine provided superior analgesia but worse side effects. So you're better off using intrathecal morphine. And then Costello, who's on a group with Carvello in Toronto, they did the tap versus a placebo, and same type of deal. They used intrathecal morphine in a spinal anesthetic, and there were no differences in pain scores, and they concluded that the tap block, as part of a multimodal regimen, does not improve the quality of the postoperative cesarean section. So if you're going to use a tap block in conjunction with intrathecal morphine, there's really no benefit. So why is it? Why is there no benefit? What's the reason? Well, intrathecal morphine, it can effectively treat both somatic pain and also visceral pain. The somatic pain is with the surgical incision and that type, whereas the visceral pain is the viscera, the uterus, that type of pain. So the tap and ilioinguinal block, it only covers the somatic pain, just a surgical type of pain, whereas the intrathecal will cover somatic and visceral. The other thing, too, is that these blocks have limited duration. So if you're just using bupivacaine or so, you might get 6 hours or something like that, although there is longer-acting local anesthetics. But I won't steal Dr. Carvello's thunder as he comes up later. So what about the tap block? So we talked about the tap block. It's not good with intrathecal morphine if you're going to use a neuraxial technique. Well, how about with general anesthesia alone? Well, Aslamian in 2012 and also Tan, also published in 2012, they both showed that if you use the tap block as part of a general anesthetic, so there's no intrathecal morphine, there is benefit. That it decreases the VAS pain scores, it increases the time to first request for analgesic, and it can decrease the 24-hour morphine consumption with an increase in satisfaction scores. So if you have to do a general, going ahead and doing a tap block can be beneficial. And then this slide, it just shows that here's the morphine consumption, and it's much less with the tap block. So the tap is black here, and here's the morphine consumption over a period of 24 hours. So definitely statistically less in it. So it is good to use for general anesthesia. Now, the other thing, too, is what you have to worry about is that sometimes when you're injecting a lot of volume on both sides, there's the potential for local anesthesia toxicity. So Griffiths she did adult female patients, and they did bilateral tap blocks, and then they measured venous blood at various time points. And you can see the various time points. And what they found was that 10 patients exceeded the potential toxic concentration of 0.15. So they concluded that you need to be careful when you're injecting these medications because you can have potential toxicity. So just be careful when you do it. Now, subsequently, when I was preparing for this lecture, that really there's just as many studies out there that say there possibly can be some toxicity. There's others out there that say no, go ahead and do it. So it's very rare that something like this would happen, but it can occur. So what's the conclusions? That without intrathecal morphine, when you're doing the TAP block and the ilioinguinal block, it can decrease pain scores and it can result in better analgesia. If you're going to use intrathecal morphine, there's really no benefit in doing it, so really not worth the time. It is beneficial with general anesthetics. It does decrease the requirement for supplemental narcotics and also the associated side effects. It can allow for early ambulation, so people that are morbidly obese or they're at risk for thromboembolism, then it'd be good to give. And Owens talked about a surgical tap block, and what they published is when you're doing like gynecological surgery, instead of anesthesia doing the block, you can actually have the surgeon do it. So when they're closing, right in that layer, it'd be the transverses and the internal oblique, they can inject local anesthetic right there. So I'm not sure many surgeons would do it, but in this study that they did it and they had really good pain scores. So it is indicated when neuraxial morphine and systemic narcotics are contraindicated. If you have a patient that comes in and says, well, you know, I just intrathecal, all I did was scratch myself and it was really bad, is there something else you could do? You can offer the tap block. And you need to be careful and have proper monitoring because local anesthesia toxicity can occur. And I will end with, a ship in harbor is safe, but that is not what ships are built for. So you need to do it. Use the ultrasound. Use the ultrasound waves or whatever. So my flight got canceled, so I got bumped to an earlier flight. So I will stay afterwards if you have any questions at the coffee break. So thank you very much. Much appreciated.